In the United States, people who are in racial and ethnic minority groups and lower income populations get sick and even die from diabetes far more than others. And when it comes to determining the reasons for these disparities, evidence shows that social and environmental factors like access to healthy food, stable employment, stable housing, and reliable transportation account for 50 to 60% of health outcomes.
Social drivers perpetuate health inequities by creating vast differences in economic opportunities, education, and access to care. What's more, few efforts have tried to address both social needs and medical needs.
Bridging the Gap, Reducing Disparities in Diabetes Care is a 5-year initiative that integrated medical and social care to combat diabetes inequities. It funded 8 teams across urban, rural, and frontier communities throughout the United States. Each showed how combining medical and social care could reduce diabetes care inequities and improve outcomes for people with diabetes. They showed that opportunities exist in 3 areas. First, holistic care teams should bridge medical care and social care. This builds trust between clinicians and their patients and should be tailored to a patient's needs. Second, healthcare institutions should partner with community groups to address social factors such as food insecurity and transportation. This expands care beyond the walls of a healthcare system and empowers patients to better manage their diabetes with community support. Third, we should adjust policy and payment systems to support and incentivize prevention and address unmet social needs, like housing, to improve outcomes. This reduces complications and improves overall care for patients.
Community-engaged research and healthcare strategies that share power with communities are critical for advancing health equity. The projects in the Bridging the Gap initiative are strong partnerships between the community and healthcare providers. We're excited to feature them in our supplement, Bridging the Gap, Transforming Medical and Social Care for Diabetes, in the Journal of General Internal Medicine.
The UPMC Western Maryland team uses a financial model that flips traditional payment for services by allowing hospitals to focus on patients' health outcomes rather than the volume of services they provide. The model rewards them for investing in strategies that can reduce hospitalization, and it allows hospitals the flexibility they need to allocate resources to the right medical care and social services. Emergency department visits and hospitalizations decreased. Mountain Comprehensive Health Corporation and St. Mary's Health and Clearwater Valley Health teams in rural Kentucky and frontier Idaho use community health workers to bridge the gap between social barriers, like inadequate transportation or access to healthy food, and better diabetes outcomes. In those communities, lay community members help their neighbors manage their diabetes, and local meal programs were utilized to support patients. In both cases, blood sugar levels dropped. La Clínica del Pueblo, a health center in Washington, D.C., partnered with community organizations to provide legal aid and healthy food programs to people who may have unrecognized immigration status. These programs have powerfully changed patients' lives and improved the health of their communities.
The diverse teams within Bridging the Gap show the power of going beyond the walls of the health system to address the root causes of inequity. Collaboration between healthcare providers and community organizations can successfully tackle pressing social needs.
Such innovative programs should be the standard of care available to all, not the exception. Payment systems should support and reward integrated medical and social care, improving diabetes outcomes and making our communities healthier.